development of the larynx, trachea, lungs, pleura, and diaphragm. And also describe the stages of development of all the upper and lower respiratory tract lah. Okay, so just a bit of recap. When fertilization occurs, you have a zygote, right? The zygote will develop into a blastula and a gastrula. So the gastrula consists of 3 layers, which are your ectoderm, which is the outermost layer, the mesoderm, which is the middle layer, and endoderm, which is the internal layer. Okay, so for the respiratory tube, mostly it comes from the endoderm or the internal layer lah. It is derived mostly from the endoderm, but some parts of the respiratory tube also come from the neural crest as well lah. We will see in the lecture later. Just to remind you where they come from the 3 layers of the gastrula lah. Okay, and for embryological origin, so the endoderm will give off epithelium and glands of the respiratory tract. Okay, the mesoderm will give connective tissue and smooth muscle of the respiratory tract. And the neural crest cells will give the skeletal muscles and cartilages of the respiratory tract. Okay, so all 3 layers give some sort of some parts to form the structures of the respiratory tract lah. Okay, so just again, just a recap of development. Okay, this is what the fetus will look like at about 4 weeks. Okay, and you have the foregut, midgut, and hindgut here. Okay, foregut, the midgut here, and the hindgut. Okay, so in respiratory system, we only focus on the foregut because this is where your respiratory system develops from lah. Okay. So first we will talk about how the pleura is formed. It's the simplest and easiest out of all because basically the pleura is formed from this intraembryonic coelom or body cavity here in the side. So what happens is just that the lung bud will punch into the coelom cavity or intraembryonic coelom, and the pleura will develop lah because it is being punched out by this lung bud. Okay, this is the coelom. Okay, so the lung bud will grow and punch out into the coelom, and finally it will develop the pleura outside of the lung. Okay, so basically the pleura is just formed by the punching out of the lung bud towards the coelom cavity. Okay, and the cavity becomes smaller and smaller once the lung grows, and finally it just it becomes 2 layers of pleura. Okay, so the parietal pleura is internal, and outside is covered by visceral pleura. Visceral is inside and parietal is outside. Okay, visceral is always stuck to the organ and parietal is the one outside. Okay, so the pleura, there's not much to talk about. It's just punching out of the lung buds punching out. Okay, and next is the so how does the pleura eventually then separates from the pericardial cavities? Okay, so before during development, like during this punching out and so on, the pleura covers the lining actually covers both the lungs and also the heart. Okay, as you can see here, the whole lining covers both pleura and the heart as well. However, the pleuropericardial folds, which is this fold here, forms and grows to the center, eventually separating the lungs in front and the heart. Okay, so so the pericardial cavity here and the pleural cavity here. Okay, and then finally when with further development, the pleural cavity will move to the right and left lah. Okay, So how about the diaphragm? How is the diaphragm developed? Okay, again, not too difficult. Basically, there's this septum transversum which grows, okay, and forms between the heart and the future liver. So basically, at the bottom here, this is the heart will be here, and this is the future liver here. So this septum transversum grows transversely from front to the back, okay, and finally muscle tissue will grow on top of this septum transversum, and that will create the diaphragm. Okay, what happens is during weeks 5 to 6, the septum transversum moves between the through the regions between C3, 4, and 5, and myoblasts will come and develop the skeletal muscles of the diaphragm on the septum transversum lah. Okay, so these myoblasts, they are innervated by C3, 4, and 5. So they drag the innervation. They drag the innervation from this myoblast into the diaphragm. That's why the diaphragm is supplied by the phrenic nerve, which is from C3, 4, and 5. Okay. So what happens at about week 8, the septum continues to grow dorsally until it meets the gut tube. So and then it stops. Okay, so you can see this is the septum transversum. It continues to grow dorsally or towards the back, and until it reaches this gut tube lah. The gut tube will be here. Okay. So because it grows dorsally and also inferiorly, so that's why at the end it is a bit lower. At the back, it is at about T12 level because it grows dorsally and also inferiorly. Okay, a bit to the back, to the bottom. Okay. So at this point, actually, there's no picture here, but there is pericardio-peritoneal canals at the back. Okay, but this will eventually close lah. Okay, and in this picture is already closed. Okay, and you have pleuroperitoneal membranes on each side from the septum transversum lah. Okay, so basically for diaphragm, the main important thing you need to know is septum transversum. Okay, and then septum transversum will grow dorsally and inferiorly until it reaches the gut tube. Okay, and then forming of the pleuroperitoneal membrane to attach to the septum transversum forms the whole diaphragm. Okay, so finally what happens is, okay, this picture is important. So from the septum transversum, it will form the central tendon of the diaphragm. The pleuroperitoneal membrane will form the muscular part. Okay, and the body wall mesenchyme will form the peripheral muscular part. This part, this orange part here is formed by the body wall mesenchyme, and the dorsal mesentery of esophagus or the gut tube just now will form the mesentery of the gut tube will form the crura, which is this U shape, U upside down shape structure here lah. Okay, so the diaphragm is quite simple: septum transversum, and then you have the pleuroperitoneal membrane and just the body wall of the mesenchyme as well. Okay, so and then they will just grow inwards and form the structures lah. From the septum transversum, it will finally form a central tendon, pleuroperitoneal membrane, muscular part here, body wall mesenchyme, the peripheral muscular part, and the dorsal mesentery of the esophagus will form the crura here. Okay, so how about moving on to the lower respiratory tract? Okay, so this again begins at the 4th week of development. So it is, as I mentioned, the foregut. It comes from the foregut. Okay, in its outgrowth from the caudal part of the foregut. There is an evagination of the foregut here. This is the foregut, the evagination forming the respiratory diverticulum. Okay, so if you see here, this is a side view and this is an anterior view. So this is the part of the foregut. okay, the caudal part here comes out and form this respiratory diverticulum. Okay, so and this is the anterior view. Okay, so finally a tracheoesophageal septum here between the future trachea and esophagus will form, okay, and divides the this portion into two lah. The dorsal portion, which is the back portion here, will form the oropharynx and esophagus. The anterior portion or ventral portion will form larynx, trachea, bronchi, and lungs. Okay, so remember, so from the foregut, the respiratory diverticulum will develop, okay, and the tracheoesophageal septum will separate the dorsal and ventral portion into two. Okay, one is the esophagus and this is the larynx trachea lah. Okay, and next, so the proximal part of the respiratory diverticulum remains tubular and forms the larynx and trachea. So this part here remains tubular and forms the larynx and trachea, and the distal ends here will form and dilate to form the lung buds. Okay, so this will give rise to your two primary bronchus lah, right and left. Okay, so we will continue with the bronchus in a bit. So just a bit of clinical correlate. So sometimes when during division of the dorsal and ventral portion here, sometimes there is an abnormality and the esophagus and trachea doesn't separate properly. Okay, and this is called, and when and sometimes there is a fistula formation. Fistula is a connection between two organs that shouldn't be there lah. Okay, so for example here between the trachea and esophagus there shouldn't be a connection, right? So because there is a connection, this connection is called a fistula. Okay, so this can happen if the development or partitioning during of these two portions is disrupted lah. Okay, so what can happen, there's many types. Okay, so you can see here in this case both there's no fistula, okay, but both esophagus didn't form properly, they didn't join together. Okay, and here there's the only fistula on the distal part of the esophagus, and here the fistula is on the upper part of the esophagus, and this is in the upper and distal portion lah, proximal and distal portion of the esophagus having fistula with the trachea. So what can happen? So if you see in these two examples here, you can see if the fetus or the baby ingests food, it will go inside the esophagus, but it cannot come down. Okay, so what happens is they get projectile vomiting of milk because anything that comes in goes right back out because there's no continuation of the esophagus, right? In this picture and this picture. But if you see here, down here, the most common symptom is aspiration, meaning the food or the milk doesn't go in the esophagus but goes inside the lungs, and that causes breathing problems lah. Okay, they get choking and coughing reflex because it goes into the milk goes into the wrong tube, which is the trachea. Okay, so that's the main complaint that the patient gets lah. Okay, here are the symptoms. So they can get cough and choke if it goes inside the trachea. Okay, and sometimes they also present with projectile vomiting in the case where the esophagus is completely it doesn't have a fistula, so it's a blind end. So whatever comes in will go back out. It's called projectile vomiting because the way it comes out is quite projectile. Okay, and that's a common feature of the TEF. Okay. Okay, and this polyhydramnios is basically in the development stage lah, meaning these symptoms happen when the baby is already born. Sometimes they can be born, but then the problems happen when they start feeding. Okay, and polyhydramnios is a condition inside the inside the uterus itself during development lah, when they cannot swallow the amniotic fluid. Okay, and that will cause polyhydramnios, so too much amniotic fluid in the uterus lah. Okay, so the problems can happen either during development or after birth. Okay, so development of the larynx. So remember from here, okay, so the proximal part of this diverticulum will form the larynx and trachea. Okay, so just to show you, this is you all are you familiar with the pharyngeal arches? I think in development we always talk about pharyngeal arches. Okay, so just to recap, if you forgot, so this is the primitive embryo. Okay, and these are your pharyngeal arches. 1, 2, 3, 4, and 6. Okay, and so if you do a cross section like this, okay, of the pharyngeal arch, and you open it up, this is what it looks like lah. Okay, so if you imagine this blue line is your ectoderm, the pink is your mesoderm, and the yellow inside is your endoderm. So going from outer to inner lah. Okay, this has been cut lah. This is a cross section. This is supposed to be like a tubular form. Okay, so just imagine we cut through this section here and open it up, and this is what you will see lah. Okay, so this is how the larynx is formed. Okay, as we mentioned earlier, the endoderm, which is in yellow, forms the epithelium and glands. Okay, and the neural crest cells, which is from the ectoderm of the 4th and 6th pharyngeal arches. Okay, so we have two types of tissue forming in the ectoderm or neural crest of the 4th and 6th pharyngeal arches. Okay, so chondroblasts of these pharyngeal arches will form the cartilage. Okay, chondroblast forms the cartilage except the epiglottis, and the myoblast, as the name suggests, forms the muscle. So chondroblast, cartilage, myoblast forms the muscles from the pharyngeal arches. Okay, so they form the muscles of the larynx. You can see here. So this is the 4th and 6th. Okay, finally they will form the muscles and cartilage lah here. Okay, and then the next slide. Okay, just a bit of innovation, because the muscula of the larynx is derived from mesenchyme of the 4th and 6th pharyngeal arches. So these are innervated by the vagus nerve, because the vagus nerve inhibits this part lah. Okay, sorry, innervates those parts. Okay, how about the epiglottis? Okay, again the same picture. Okay, so but instead of being formed by the neural crest cells, the epiglottis is formed by the hypobranchial eminence. Okay, which is this here in the middle here. So this hypobranchial eminence will develop into the epiglottis. Okay, so you can see from here 4 weeks, 5 weeks, and then finally it becomes like more to the side. Okay, and then finally it becomes the epiglottis that we have lah. Okay, at 10 weeks. Okay, so also if you notice in the larynx, okay, you can see development of the larynx at 6 weeks. There is closure. You can see a T-shaped structure here, in which during development, because of the rapid proliferation of the laryngeal epithelium, it causes temporary occlusion of the laryngeal lumen. This is what it means, because of the epithelium growth, which is more rapid than the other parts. Okay, so at one point during 6 weeks, there is closure of the laryngeal outlet. Okay, but once the other structures also develop, at 10 weeks, the laryngeal outlet will open, or inlet, sorry. Okay, so so this is called recanalization lah, because there is temporary occlusion at 6 weeks, and then at 10 weeks here in this picture, this is called recanalization of the larynx. Okay, and what happens during recanalization is the forming of the vestibular fold and vocal fold, forming the ventricle here. Okay, so that's the larynx. So just to recap, coming from the pharyngeal arches, the endoderm will form the epithelium and glands of the larynx. The neural crest cells, which is the ectoderm of the fourth and sixth pharyngeal arches, will form from the chondroblast, will form the cartilage. The myoblast will form the muscles. Okay, and they are innervated by the vagus nerve. The epiglottis is formed by the hypobranchial eminence. Okay, and also there is a temporary occlusion at about 6 weeks, and at 10 weeks all the other the vestibular fold and vocal fold is formed, causing recanalization or opening of the laryngeal inlet. Okay, so temporary closure at 6 weeks and then reopening or recanalization at 10 weeks. Okay. Yes. Okay, can I continue? Okay, so from now we move on to trachea. So it's basically from the same lung bud here, respiratory diverticulum. Okay, so again we talked about the larynx here, and now we move on to the trachea. So how is the trachea formed? Okay, so the endodermal lining as usual differentiates into epithelium and glands. Okay, the cartilages again are derived from the pharyngeal arches, and the connective tissue and smooth muscles of the trachea are formed from the mesoderm. Okay, so you can see here endoderm forming the epithelium and glands. Okay, and here cartilages from the pharyngeal arch, and the outermost layer, which is the connective tissue coming from the mesoderm. Okay, so how about bronchi and lungs? So again, from the bronchial respiratory diverticulum forming the lung buds here, right? Okay, so the formation of right and left primary bronchial buds finally divide into the secondary bronchial buds. So you have 3 on the right and 2 on the left. The right main bronchus is slightly larger than the left one, is more vertical. Remember, even in adult, the same thing occurs, mainly because on the left side you have the heart, so it is more horizontal as compared to the left. You don't have the heart, so the bronchus is more vertical and slightly larger lah, because it has 3 secondary bronchi, right, coming from the right side. That's why if there is inhalation of any, say for example, children, sometimes they inhale peanuts. What else? You can see all this during your trauma attachment, emergency department attachment. There's so many cases like this. Okay, sometimes toys, like small toys and small food comes and they get lodged on the right side of the lung, because the right side is more vertical as compared to the left. So because it's more horizontal, so usually whatever comes in like a foreign body, they usually get stuck in the right side of the lung. Okay, the main bronchi then subdivides into secondary and tertiary bronchi, which give rise to further branches. So basically from the lung buds forming right and left main bronchus, from the right main bronchus there's 3 branches forming the secondary bronchi, 2 on the left, and then forming more segmental or tertiary bronchi. So during 7th week, about 10 segmental bronchi is formed in the right lung, and on the left, usually about 8 or 9 lah, slightly less. Okay. Surrounding mesenchyme here in pink also divides together with the lungs. Okay. So by 24 weeks, it basically this division here just occurs until birth lah. But by 24 weeks, you have already about 17 orders of branches, and you have development of respiratory bronchioles already. Okay. And the lungs assume a more caudal position, meaning they go down. Okay. So that by the time of birth, the bifurcation of the trachea is opposite the fourth thoracic vertebra. So they go down until the trachea becomes at the fourth thoracic vertebra level lah. Okay, so just a bit on maturation of the lungs. So how they form is just by more branching and branching. Okay, so how do they mature into functional lungs? Okay, so there's 4 periods or 4 stages. From 5 to 17 weeks, the stage is called pseudoglandular because they look, the appearance are like a gland. Okay, and 16 to 25 weeks, it's called canalicular. 24 weeks until birth, it's called the terminal sac period, and later fetal period until childhood. After birth and until childhood, it's called the alveolar period of maturation. Okay, but sometimes they overlap each other. There's no clear cut at what weeks it stops and so on, because sometimes this still continues until this is properly going on lah. Okay. So the first part or the first stage is the pseudoglandular period. Okay, between 15 to 17 weeks of fetal life lah. Okay. So it's called pseudoglandular because it resembles an exocrine gland. Okay, just resembles, it doesn't function like an exocrine gland. Okay, because you can see the main feature is there is cubic which is a precursor for the ciliated epithelium and goblet cells in the future lah. Okay, and you also have the capillaries already, the connective tissue, and terminal bronchiole. Okay, but this is very premature. There is no gas exchange. If the fetus is born at this stage, gas exchange cannot happen yet because this is not ready for gas exchange. Okay, so the canalicular period is where the lung tissue becomes more vascular, so more capillaries inside. This pink shape, rounded shape structure is the capillaries. Okay, and the lumina of the bronchi and terminal bronchioles become larger. Okay, so all this becomes larger, and by 24 weeks, the terminal bronchiole has given rise to 2 or more respiratory bronchioles. So they will develop respiratory bronchioles. Okay, and the respiratory bronchioles divide into 3 to 6 tubular passages called the alveolar ducts. So alveolar ducts have formed by the end of the 25th or 24th week lah. Okay, so because of that, respiration is possible at 24 weeks. Okay, so if a fetus is born prematurely at 24 weeks, they can survive. However, they don't have enough like surfactant and so on yet. So it's still an immature lung, but they can with proper intensive care support lah, because they already have the alveolar ducts. Okay. And they also already have the pneumocyte 1 and 2, but very premature. So sometimes it's not enough for them to survive, but if they get intensive care and proper medication and so on, they can sometimes survive lah. Okay, but before 24 weeks, it's not possible because they don't have the alveolar ducts and they don't have all these vascular, not enough support for respiration lah. Okay. So next is the terminal sac period. So this begins at 24th week, so after the canalicular period until birth. Okay, so as the name suggests, terminal sacs develop here. Okay, the epithelium here becomes more thin. In this picture, I don't see it's becoming thin, but supposedly it becomes more thin, lah. Okay, and then the capillaries begin to bulge into the alveoli, so they start connecting to the alveoli. Okay, and this connection will cause the blood-air barrier to develop. Okay, so adequate gas exchange can occur, which allows the prematurely born fetus to survive. So imagine this is happening between 24 weeks to birth. So if the baby is born here during this time, the gas exchange can already occur, okay, but it's very premature. But this process will mature even more until birth. So at birth, they should have been prepared and gas exchange can occur continuously lah. Okay, so just to touch a bit on the pneumocytes. So by 24 weeks, the terminal sacs are already lined by type 1 and type 2 pneumocytes. So so because the type 2 pneumocytes create the surfactant, so surfactant production begins at about 24 weeks lah. Okay, and fetuses born, I think I explained all this already. Fetuses born prematurely at 24 to 26 weeks may suffer from respiratory distress due to surfactant deficiency. So they can have some respiration, but still the surfactant is not enough, so they can survive if they are given intensive care lah. Okay, so the final period is the alveolar period. Okay, this is between 32 weeks and to 8 years of age lah. Okay, so meaning if a baby is born a bit prematurely at 32 weeks, inshallah they will survive because their lungs are already quite mature lah as compared to the 24 week which just started having surfactant. Okay, so at the beginning of the alveolar period, each respiratory bronchiole terminates in a cluster of thin-walled terminal sacules separated from one another by loose connective tissue. Okay, what this basically means is just that the walls are already very thin at this stage, so gas exchange can occur very quickly. Okay, so epithelial lining of the terminal sacs attenuates to form an extremely thin squamous epithelial layer. You can see very thin epithelial layer to allow fast gas exchange lah, and you have the type 1 and type 2 alveolar cells or pneumocytes lah to help with surfactant and production of surfactant. Okay, so the mature alveoli do not form until after birth. Okay, about 50 at birth. About 50 million alveoli, 1/6 of the adult number, are present in the lungs in the full-term born infant. Okay, so increase in the size of the lungs is due to the increase in the number of the respiratory bronchioles rather than the size of the alveoli. Meaning from birth until now, the size of the alveoli increased very little, but how does the increase in size of the lung happen? It is due to the increase in the number of bronchioles. Okay, so that from birth until the age of 8 years old, a lot of respiratory bronchioles will be formed. More bronchioles will develop lah. Okay, so here you can see by about the age of 8 years, this is when the development of your lungs stop actually. Not at birth, but until the age of 8 is when you have the number of adult alveoli, which is about 300 million. That's quite a lot. Okay, so from 50 million from during birth, it will further develop until about 300 million lah at the age of 8, and then it stops there. Okay, so just a bit on the lungs at birth. Okay, this is a very important process. That's why when an ONGs or a pediatrician in the labor room, they want to hear the first cry of the baby because that means that the lungs have been filled with air. Okay, if you imagine the lungs inside the womb is half filled with fluid, right, coming from amniotic fluid and some from the glands as well. Okay, so how is the fluid in the lungs cleared at birth? By inspiration of air. So it's very important. The first breath of the baby is very important to clear out this fluid and make sure he or she is able to breathe lah. Okay, and the lungs will open up, pop up like that. Okay, so the fluid is cleared by pressure on the fetal thorax during delivery due to inspiration of air. So the most important thing is for the baby to inhale air at the first breath, during the first breath lah. Okay, and all this fluid will be absorbed into the pulmonary capillaries and lymphatics. So it is also important to have surfactant, enough surfactant, which is, you all know what surfactant is? It's protein produced by type 2 pneumocytes. Okay, and it causes a thin phospholipid coat on the alveolar cell membranes. It creates tension on the alveolus so that it doesn't collapse. Okay, so with air entering the alveoli during the first breath, the surfactant coat prevents development of an air-water or blood interface with high surface tension. So without this surfactant, the alveoli would collapse, and this is called lung atelectasis. Okay. So so what happens if the premature baby doesn't have enough surfactant? They can have respiratory distress syndrome. Okay, because without the surfactant, this is a normal alveoli with surfactant. You can see nice rounded shaped alveoli, but without the surfactant, there's not enough tension created on the alveoli, causing the alveoli to collapse. Okay, and because of that, they don't get enough oxygen to the brain, and that causes death lah. Okay, so what is this called? Okay, but sometimes this can be prevented by if say for example the mother is having premature contraction, so the baby wants to come out prematurely. Sometimes they can get as early as 24 weeks, and sometimes say for example at 30 weeks the mother gets contraction. So we will give the mother glucocorticoids, because this will stimulate surfactant production in the baby to prepare for premature delivery. Okay, and sometimes they use thyroxine as well to stimulate surfactant production. Okay, so other clinical correlates, but in these correlates, usually it doesn't cause much trouble until you do certain procedures. So for example, supernumerary lobes, meaning extra lobes. So example here you have cardiac lobe, accessory lobe, diaphragmatic lobe, and so on. Okay, there's supposed to be 3 and 2, right? Okay, some people might have accessory lobes, but because this happens during the division of the bronchial tree. Remember, they divide into 300 million alveoli and so on. Okay, so sometimes during the division, there is some abnormality and cause these extra lobes to be formed. However, it will not cause a problem usually. Just maybe they have more lung tissue lah. Okay. So and usually they find it during doing bronchoscopy, and they say, what's this lobe here, and so on lah. They have more lobes to enter lah. Okay, but no problems usually with the patient. Sometimes they can also have ectopic lung lobes. Okay, so sometimes from the trachea they find a lung lobe there or at the esophagus. Okay, these lobes are formed from additional respiratory buds of the foregut. So meaning during the foregut the respiratory bud formation from the foregut, 2 of the respiratory buds formed instead of 1, for example. Again, with this usually if there's no problem if they separate, if there's no fistula, it won't create a problem. Okay, so I think that's all for development. Thank you very much. Oh, can you take the attendance, please?
Alright, doctor. I've sent the attendance in the meeting chat.
Okay, thank you.
Doctor,
Yes.
I have a question.
Okay.
Why does the right lung was able to form three alveoli, if I'm not mistaken? And
You mean three
three
secondary
bronchial buds.
bronchus?
Ah.
Three bronchus.
Why is the right lung able to do three, but the left lung is only forms two?
It's because of the heart. Okay, because on the left side you have a heart here, so you cannot afford to have a big lung as compared to the right side. You don't have the heart, so you can fill the whole cavity with the lungs. Here you have the heart, right?
Yeah. Okay, thank you, doctor.
Okay, so thank you very much. I'll see you for tomorrow for the lab, starting at 9. Okay, thank you very much.
Thank you, doctor.
Doctor.
Thank you, doctor.